Welcome to today's MESUD Learning Community Echo, Adolescent Medicine, How SUD Fits. Today we'll be hearing from Dr. Brock Libby on gender health. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. And now I'd like to give a brief introduction to our speaker today. Dr. Brock Libby has recently joined the Maine Medical Partners at South Portland Pediatrics. His clinical interests include LGBTQ youth, hormonal contraception, and young men's health. And with that, I will hand it off to Dr. Libby. Thank you all for being here today.
Morning, everyone. This is a very hot ticket item these days. So if folks have questions, just go ahead and either put them in the Q&A or we'll chat about them when I'm done. I know that there's a lot to discuss about this stuff, so my didactic is going to be a little bit longer than the other ones, and then my case, I obviously have a case, but that'll be a little bit quicker. So yes, like I said, I'm Brock, Dr. Libby. I'm fortunate enough to be the medical director of the gender clinic here at Maine Health. Really important thing for me to say, I am cisgender. I have not lived the trans experience. It's really important for folks to know and recognize that. So I do use he, him, his pronouns. So this is just a brief outline and we'll get to all these topics. Going to just really touch on anti-trans legislature, just talk about special considerations, and then we'll really sort of talk about the medical treatment of these folks. I really chose to focus on the medical treatment because that's really what I do. There's extensive behavioral health work that's done with these folks that's left out of these, that's left out of this presentation. I'll briefly touch upon it though, and the services that are provided at our gender clinic. And I'm going to talk about in the context of our multidisciplinary gender clinic. It's really important to know that there is a move to have a lot of this work be done in primary care offices. So the setup will be a little bit different, but if folks have questions about that, just go ahead and ask me at the Q&A. So this just shows the anti-trans legislature that's going on across the US. It is very sad and abysmal and a little bit confusing that the GOP is targeting this population, but it's what they're doing and it's what's been occurring for a bit of time now. Thankfully, we're in a protected state, so that's great. There's still some fear that some federal funding could be cut off to Maine Health, and then we'd have to sort of scurry and figure out how to provide the care. I had a national meeting with folks yesterday afternoon, some folks at Planned Parenthood who have really learned how to sort of break up their care so they're not breaking any of the rules. But basically, like Planned Parenthood folks who are in these red states where abortion's been criminalized. So that was good, but we're worried about this and we're scared for what the future holds, but we're holding space right now and supporting the patients the best we can. So I just really want to talk about special considerations. I don't always love these slides because I don't want folks to think of transgender youth, transgender adults, and addiction, but just know that these things really, really run hand in hand. The incidence of addiction and drug abuse is listed there. So basically 2 times likely to misuse prescription pain medications, 2.5 times likely to use other substances, and 3 times likely to smoke cigarettes and things like that. And these are all, of course, coping mechanisms. I am definitely the type of person who's like not always I don't ever tell a patient you need to stop doing X substance because it just doesn't work. I try to really partner with the patient, look at the reasons and the etiology behind it, and go from there. But obviously there are some substances that can lead to death. So just know that these are addiction runs in this community, and it's a coping mechanism for their stressors. This is just a little bit more sort of in our wheelhouse, adolescent medicine. This just really talks about stuff that happens at schools. This is from the CDC. The number there says 2% high school students identify as transgender. That's actually probably doubled. It's closer to 4 based upon recent national and statewide surveys, but it's probably somewhere between 4 and 6. It's really, really hard to know. But it's important to know that over a quarter feel unsafe going to school, over a third are bullied at school, and over a third have had a suicide attempt. These are staggering numbers and really, really worrisome, and something that we should be thinking about and focusing on. My greatest fear, of course, is that these are all going to worsen with the new administration coming in. So we're just going to have to be hyper vigilant. Of course, the thing that scares me the most is that it's going to be the worst in red states, which we don't live in. But there are plenty of really good adolescent medicine docs who live in those locations. But it's hard and it's scary. Next slide, please. So I'm going to talk about GnRH analogs. So this is where we're getting into the medical treatment of these folks. And I'm just going to sort of start chronologically. And so how it would work in our gender clinic is if a referral comes in for a patient and they are around the age of puberty or the beginning of puberty, that's when we really want to sort of pause and see if we need to get that person in for an urgent evaluation and to urgently start them on Lupron. So that initial urgent evaluation would be done by a behavioral health provider in our clinic, either a therapist or a child and adolescent psychiatrist. As of right now, we only have one therapist, but we're hiring a second therapist, and we have a child and adolescent psychiatrist who's going to start the second Monday of January. So we have some increased workforce there. So basically, these folks come in and they are, again, they're referred. We process the referral. We have them meet with behavioral health. Sometimes they need one or two visits because basically the behavioral health clinician just wants to make sure this is the right match for this patient. And then the other part, which as folks can probably guess, the trickier part is getting to assure that both mom and dad are aligned and are on board with this. Generally, they're aligned, but obviously the trickiest clinical situations we have are those who are not aligned and they really sort of they weaponize their kid. It's really sad and really challenging. It's very rare, but it does happen. So for folks who aren't familiar, there's Lupron. So this mimics a signal from the brain to another part of the brain to start puberty. With this GnRH analog, that signaling is shut off, so there's no pubertal progression. We do not, I want folks to hear me say this really clearly, we do not start this before puberty. There was no prophylactic initiation of Lupron. The reasoning there is because if there's pubertal pathology, we would completely cover that up with GnRH analogs. So we do not recommend ever to do that. We always really want to catch these folks. So the reason why it's urgent is that we have 5 stages of puberty. Puberty stage 1 is we haven't started puberty. Stage 5 is we're done. So really we want to catch folks right in stage 2 of puberty to start this. And the goal there is 1, it pauses any somatic or bodily or physical development while they're working with our behavioral health team in the clinic to determine if the future is for gender affirming hormone or if the future is for them to come off the Lupron and have their own natal puberty. I would say in our clinic, we're incredibly biased because we're a gender clinic, but about 85% of our folks go on to start gender affirming hormone, but it is about 50% who come off and go through their own natal puberty. And so the goal there is there are no bodily changes. There's no forward progression in puberty. And if these folks in the future would like to have some sort of gender affirming surgeries, this pausing here would not necessitate removal of extra tissue. You would obviously still have to go in and do the surgery if that's even indicated, but like something like top surgery for transmasculine folks, which is removal of the breast tissue, that would not need to be done if Lupron is started at the right time and initiated then. So this is just, but it's important also for folks. So this is a really small subset of our population because this is a population where we have to meet them, um, where we have to meet them at the right time in their pubertal development in order for us to have this work correctly. So there's a lot of things that need to align there. So probably only about 15 to 20% of our patients in our clinic actually are met at the right time in life and are put on Lupron to pause puberty. Next slide, please. And just so folks know, in general, humans born into a body with a penis, they start puberty at 11.5. Humans born into a body with a vagina, they start puberty at about 10.5. So those are sort of the standards that we're looking for and the ages and the cutoffs that we're looking for these folks. If these folks aren't in the right stage of puberty or haven't started yet, we meet them for a physical exam. We order pubertal labs. If the pubertal labs show no sign of puberty, we check labs every 3 months until they start, and then we initiate. Like I said here, yeah, so we don't meet everybody here. There's no recipe. It's not like sort of having a sourdough starter. You don't do X, Y, Z. There's a lot of different things that need to be done for the process, and not everybody goes on Lupron, like I said. So I first want to talk about transmasculine youth and transmasculine youth, just so we're talking in sort of concrete data here. Born into a human with a vagina, but identify as a male. So those are generally called transgender males. However, I have done this multiple times and I have been slammed by people who are like, I don't identify as a transgender male. I identify as something different. So this is the blanket umbrella term that I use. And it's transmasculine youth. It seems to be the least one that gets some pushback from it. But in these folks, the first step for them is, so say we get a referral for someone who's a 14-year-old transmasculine youth. They're seen by behavioral health, and then they recognize that this patient could benefit from menstrual suppression. So then they're sent over to the clinical team. So menstrual suppression is really, again, we're beyond the point in pubertal development and somatic development in the body that we're not going to use Lupron just because it's not feasible. It's too expensive, too many side effects. So at that point, we use standard, usually oral contraception for this process, but you can use any type of contraception for this. It's just really, really important for folks to know. John knows this about me. John knows I'm very biased. Do not recommend folks do continuous cycling of their combined oral contraceptive. So let me break down what I mean there. Continuous cycling means skipping the placebo weeks, and combined oral contraceptives means it has estrogen and progesterone in it. In those folks, the lining of their uterus or the endometrium will build up, build up, build up. And in 86% of folks under the age of 22, they will have breakthrough bleeding. They will have breakthrough bleeding because their endometrium is built up so far that the only thing we can do is have them have a bleed. So I do not recommend extended cycling of combined oral contraceptives. Now, there's 15% of folks who it works beautifully, but that's such a rare number that I really avoid it. So the things that I use most commonly, and these are this is what's used nationally as well. I would say agestin is the one that's used the most commonly here. Agestin is norethindrone, and it's a oral progesterone only pill. Just really important that you tell folks you really want to take this medication at the same time every day. And these folks really will not bleed at all if they do a great job. It's a pretty rigid medication. So if they're late, like say, I don't know, on Monday they take it at 4 p.m., on Tuesday they take it at 6 p.m., they have a little bit of a bleed. These folks are really good at self-regulating and figuring out sort of what they can do to take their medicine not to bleed. Really important thing about agestin is that after folks have an orgasm, either from masturbation or from having sex themselves, there can be a light bleed. The thought is there's a small uterine contraction with an orgasm that leads to that. I just tell folks this because an orgasm is positive and bleeding is negative. I just want them to be aware of this. And then there's Depo-Provera, that's intramuscular every 3 months. This is 150 milligrams of hydroxyprogesterone acetate. I'm biased. I don't like this medicine. This medicine is really tricky and tough for folks. There's a lot of side effects, including weight gain. But the one thing about it that's really great is that this really leads to menstrual suppression within 9 months. Folks do such good job and don't bleed. But it's a really strong, powerful medicine and has a lot of side effects that Dr. Libby doesn't love, and I'm biased about it. The other one that I use pretty often is Seasonal. So this is an extended cycling combined oral contraceptive. Extended cycling just means instead of a 28-day pill pack, you have a 91-day pill pack. You have 84 pills in it that have hormones in it, and you have 7 that don't. Folks want to go on this because the reason why transmasculine folks will tell me why they want to go on this is because with this one, they know when they're going to bleed, and that bleeding for them and for some folks is really important because then they know that they're not pregnant. They worry about being pregnant on these items where they don't bleed at all, so that can stress them out a little bit. I provide reassurance, but it can bother them. So with agestin and with Depo-Provera, you have no menstrual cycles, but with seasonal, it's important to know that you have 4 menstrual cycles a year, which these folks can tolerate. Again, it's sort of shared decision making with the patient. And then the next step for transmasculine use is gender affirming hormone. So I've put down here the 4 types of testosterone that we have. Testosterone cypionate is an injection. It's subcutaneous. It's every 7 days. We generally start at 50 milligrams every 7 days, and we don't waver from that a lot. This really requires a teach visit. We want folks to have the tools to give the dose themselves, and we don't want sort of mom with diabetes doing it at home just because at some point you're going to move out of living with mom, and we really want folks to have the tools for that. There's also testosterone gel. This sort of comes just like a standard moisturizing body lotion, and you start with sort of 1 pump once a day. It's transdermal, so folks just put it on their skin and then they're good to go. They do need to wash their hands after. Folks are worried about contamination, but that risk is really quite low. The one thing I would say with testosterone gel is folks really struggle to suppress their menstrual cycle, and you can continue to push the pumps of tea every day, but that's just really hard for folks. So I make sure to tell folks that a lot of transmasculine folks will still have their menstrual cycle on the tea. We're not fully sure why this is. We just think it's not as powerful enough and the concentration in the body doesn't get high enough to lead to clinical amenorrhea. And then the other form is Testapel or testosterone pellets. These are fully managed by urology. I don't fully know the history here about why they're managed by urology. It does require a procedure, but the procedure is pretty minimal. So they come in every 4 months. It's about a 20-minute procedure. Superior to the right buttock, there's a small incision made and pellets are placed. The amount of pellets are placed based upon most recent lab results, and the pellets actually are absorbed by the body. So there's no removal. And so it's just every 4 months that folks need to go in. This sounds good, but I think the negatives are that every 4 months tends to come around pretty quickly for folks. And the timing of the labs is much more rigid with this. I would have to have urology here to tell you about it, but it's sort of like after the pellet's placed, like 3 weeks later, you have to get a lab value, then you're going to get another lab value sort of down the road. So there's a lot more laboratory monitoring with this, but some folks do like it. In general, with those folks, since it's urology, adolescent medicine, gender clinic still sees them every 6 months just to check in psychosocially and to make sure there's no sort of legal questions. And then the last one is a real big black box. It's oral testosterone. It's testosterone undecoate. I've had no luck getting this prescribed. I've tried it 3 times, and every time it's been denied by insurance. Our adult provider, Dr. Dan Spratt, has 3 patients that are on it. He's somehow gotten it approved. It's a little bit more challenging to get approved from insurance. Again, I think it's probably because it's a little bit more expensive, and I don't know the full story there. Lots of folks ask for this, but again, I've been super unsuccessful. When they ask, I attempt, but boy, I usually get a denial really quickly. And so this is probably the most important part of the talk right here. If folks are going to be managing transmasculine folks on their own, you can use any of those formulations. I gave you the starting dose. You want to monitor the testosterone level every 3 months in the first year, every 6 months after that. This is your therapeutic value range for testosterone. It's 350 to 750. Sometimes we make dose adjustments with this, but I really try not to. So like our clinical team will call and be like, oh, your most recent T value was 210. What's going on? And the patient will be like, oh, I don't know. I've not missed any doses. I'm doing great. And then if I check with the patient, they're like, well, the week before I got it, I only gave myself my T gel twice. So we get sort of like varying information. I think that that's common with any sort of patient interaction, but I really try hard not to make a lot of these dose adjustments on these folks, especially with the injectable, just because you have to pull up to such a specific number on the syringe that sort of doing that and changing that, it can get a little bit arduous to folks. However, having said that, we do change these doses every now and then, but it's pretty rare. So this is an important slide here for folks, and folks can hopefully find this online. If they can, I can get it to you. But this is really sort of your expected timeline and effects for gender affirming hormone therapy. Now, I want to talk about, so it says here what's irreversible, reversible, and variable. So I just want to be clear that in the media, in the news, anywhere, you can hear folks talk about detransitioners and regret. This is not ever a phrase that I have ever heard a patient say to me. ever. I have taken care of probably 30 folks who have started on gender affirming hormone and have stopped. They've stopped for very specific reasons. I just want to be clear to everybody on this call, not one of those reasons is regret. It's because they got the changes they wanted and then they stopped. Now, it's a little biased because I'm the one who writes the prescription, so they're not going to like be super honest about saying, I regret what you did. But it's so rare that we hear this. And really, what I will say is I'm going to challenge this document here because scalp hair loss is reversible. I've seen folks lose hair from their testosterone therapy, and then after they stop, about 24 months later, their hair on the top of the head returns to back to what it was prior to starting testosterone therapy. The deepening of the voice, so basically your vocal cords get thicker from the testosterone therapy. There's no way to make them thinner except there is now a surgery done by laryngologist who can actually thin the vocal cords. I don't have great data on this. I just know that it now exists, but it happens pretty rarely. And I sort of am a little bit scared about somebody going in and scraping off somebody's vocal cords. But I guess if I'm going to trust someone to do it, it would be a laryngologist. The other thing about this too is the facial and body hair growth. I've seen that return. The one thing that is definitely permanent for these folks and is irreversible is their clitoral growth. So these folks will really come to us and report that after their first injection of T, they notice their clitoris grew. The amount of growth is variable. The growth is usually not cumulative. There are lots of things that transmasculine folks do to try and increase the growth of their clitoris. We haven't had anything be super successful or pan out. So basically what happens if they're on T therapy, their clitoris will grow. If they stop, the clitoris will actually shrink, but it won't get back to the size it was before testosterone therapy. Hopefully that makes sense. So the clitoris is just a little bit bigger in those folks who have been on T and then stopped after a while. So that's really what I say is the voice and the clitoral enlargement are the only things that are fully irreversible in this patient population. Um, Going to talk about trans feminine youth. So for these folks, there's also a two-step process here. Now we're going to pretend like this is somebody who came in later in life, not a candidate for Lupron because based upon where they are in their pubertal development. And so for those folks, what we generally use is spironolactone. There are some other things that are used, but that's a little bit more esoteric. Just know spironolactone does not affect testosterone production, which occurs in the testicles. It only is going to block the receptors of testosterone throughout the body. So it's going to minimize the impact of testosterone, the testosterone in the body. Really important for folks to know on this call. It is not supporting your patient to start them on spironolactone before they see the gender clinic. Folks who are started on spironolactone before being put on estradiol therapy generally have pretty significant fibrotic breast tissue that they are not pleased with, which will necessitate surgery in the future. So I really strongly recommend don't do spironolactone before starting somebody on E. I know it can feel supportive, but in the long run, it actually leads to some negative things. And trans feminine. So now this is the gender affirming hormone for trans feminine youth, young adults, and adults. So in general, we use estradiol tablets. There is a huge discussion in the community if these should be swallowed or these should be done sublingual. What I can say is that we've done a little mini research project in our clinic, and we have found that there's no difference in sort of estradiol levels. But it's really important when we talk to this community that how they feel versus estradiol levels are very different things. So there are many folks who feel very strongly that putting it under the tongue and letting it dissolve works better for them. Others swallow. I tell folks to trust their community around them and to do whatever they feel is best because we don't have any data saying one way is harmful or anything else like that. And when I say trust your community, I mean it when I say, I'm someone who grew up in academic medicine. I went to Children's Hospital of Philadelphia for fellowship, but I access Reddit when I don't know answers about gender diverse youth because the information is going to be on Reddit before it's published in any type of scientific journal. So I do use Reddit very often. In general, clinical research lags about a decade behind the actual clinical medicine that's being done. So we're just seeing a lot of research being done right now. I'm not advocating for everyone to go out there and cite Reddit, but it's a really important resource in some of these forums. So like I said, we do oral estradiol and we also do injectable estradiol. Injectable estradiol is called estradiol valerate. We generally start folks at about 0.2 milligram. I'm sorry, 2 milligrams every 7 days. But what we do most often is folks start on the oral formulation and then transition to the injectable in the future for a variety of reasons. There are estradiol patches, but I don't recommend them. Us in our clinic, we fought and struggled with them for about 6 to 7 years before getting rid of them. And the problem here is, like I'll say on the next page, with trans feminine youth, you need to do two things. You need to bring the estradiol up, but even more important, you need to suppress the testosterone. Testosterone, in terms of phenotypically how we present, is much stronger than estradiol. So you really want to suppress that T. We were unable to effectively suppress testosterone with patches, so we moved away from them. Now, like I said, with transmasculine use, there's not a lot of dose manipulation, but with this population, there is a ton. So basically, I start all folks on 1 milligram twice a day if they're going to do oral, and then we do labs every 3 months. It's super important that with trans feminine youth, your laboratory monitoring is a testosterone value and an estrogen value. So if you remember about transmasculine youth, you're just looking at a T value, but in trans feminine, you have to assess both because again, you're looking for suppression of T, elevation of E. And the reason why we don't just start folks on 4 milligrams a day of estradiol, right? Like, why don't I just start 2 milligrams twice a day? So there is a phenomenon. Again, we talked about fibrotic breast with spironolactone alone, but the phenomenon is called tubular breast in this situation. If you start with too high of a dose of exogenous estradiol too quickly. There is, of course, some data out there. I feel that it's sexist, but there is some data out there saying that too high of a dose too quickly of estradiol can lead to psychosis. A bunch of actual research has been done. There's no connection there, and that's not actually anything that's ever been seen, but it is something that folks do perpetuate. So we don't do it because we're worried about psychosis. We do it because we're worried about their breast shape and how their breasts look. And some of our pediatric endocrinologists, even if they start someone who's 15 on E, which generally we start folks around 16, if they start folks who are 15 on E, they actually start them on 1 milligram a day. And they have reasoning for that. Outcomes are nearly the same, but just know there's some variability in those who are 15 under 16. But in general, 1 milligram twice a day will be a good starting point for you, along with your 100 milligrams twice a day of spironolactone. And so here's the other really important slide for everybody. If you're doing this on your own, then these are the lab values that you really need to go for. You want your T to be less than 50 and your E above 100. Now, the only way to actually suppress testosterone production is with estradiol therapy. Of course, if they also have an orchiectomy, that works great too. But this is really the main way to do it. And I think the next slide is my case. That's the name. I could be wrong. Oh, so here are the changes from estradiol therapy. And the only one that's really reversible is going to be the breast tissue growth. And it's much rarer in my experience for trans feminine folks to start E and then stop it. So I've had just a small subset of folks who have done that. And there is basically the breast tissue shrinks down, but you can still see that it was there, and that would necessitate some plastic surgery intervention to have that be done. But the rest of the stuff is really quite variable. Importantly is behavioral health involvement. I strongly, strongly, strongly encourage everyone to have behavioral health involvement. And it's really important to say to patients, I'm not having you see a therapist so the therapist can verify that you are who you are. I'm having you see a therapist so you can understand the ramifications of this medication and also have appropriate goals and have appropriate expectations for what this is going to do for your life. And it's speaking of expectations, I don't mean to be heavy and end on a negative note, but it's the most vulnerable time for these folks. We originally thought it was before they start gender affirming hormone, like they're really eager to get on, the emotional stuff is going to be really challenging. But as we've done this work and we've got more into it, the most vulnerable part and most vulnerable time for these folks would be the 4 to 6 weeks after initiation of this hormone. And the reason for this is because a lot of these folks, I think, believe that I'm going to take this estradiol and this spironolactone and it's going to solve everything about me. It's going to take care of my anxiety, my depression, the trauma I went through, my OCD. And what will happen is folks will start treatment and start therapy, and they will have their gender dysphoria be treated, but they're still left with themselves. And that sense of permanence and knowing that they're always going to have that trauma as be part of them can be really, really challenging and hard for these patients. Sexual health is a whole other discussion that I have with my patients, but I think it's really, really important. All humans deserve to have a healthy sex life, so I do go into that type of stuff. We use estradiol cream for transmasculine folks that they place inside the vagina. We use either Viagra or PrEP or both for transfeminine folks, depending on their needs and what they desire. But I think I will stop there.